Hello, my name is Pip Nicolson. I'm a clinical lecturer in haematology at the University of Birmingham, as well as a registrar in haematology at University Hospitals Birmingham NHS Trust. I'm also the co-founder and current chair of the HaemSTAR Network. I'm very grateful to the conference organisers for the invitation to speak to you today about the HaemSTAR Network, and particularly one of our projects looking at the dosing of intravenous immunoglobulin for the treatment of ITP. These are my conflicts of interest. I've received both personal research funding as well as funding for HaemSTAR from various industry sources. The take-home message I have for you today is that primarily it is safe to follow the NHS England guidance for the use of intravenous immunoglobulin in ITP, and that this should be used as a 1 gram per kilogram one-off dose, and that repeat doses should only be considered after sufficient time for a response assessment if there is failure to achieve a hemostatically adequate platelet count. I also wanted to be clear that if everyone in the UK who currently uses 2 doses of 1 gram per kilo on consecutive days, if they switch to using a single dose of 1 gram per kilo, this would save the NHS £1.5 million per year. The other take-home message is that there's evidence that UK haematologists dose cap IVIG if the patient's weight is more than 100 kilograms, and this appears to be a safe practice. The overview of the talk I'm going to give is firstly explaining the HaemSTAR network, the rationale for why it was set up, how it was structured and how it functions. I also want to go over the studies that HaemSTAR has led or helped deliver in ITP, but the majority of the talk will be looking at a particular project that we led that we call the Flash Mob project that looked at the dosing of IVIG for patients with ITP. The HaemSTAR network is a registrar-led UK non-malignant haematology network. It was set up in 2017 to address specific bottlenecks in the UK research infrastructure. It helps train registrars on how to be principal investigators leading clinical trials in individual hospitals, and it also aims to help open studies in a more smaller district general hospitals rather than just in tertiary referral teaching hospitals. Over the last 5 years, it's developed into a series of 24 hubs throughout England and the devolved nations, where each hub has a regional lead who takes instruction and communication from the small and agile central committee, and also who coordinates study activity in all local hospitals in their region. So far, in the last 5 years, it's led and assisted multiple studies, but particularly in the field of ITP, we've assisted with a real-world data study looking at outcomes from patients treated with the thrombopoietin receptor agonists. We've also helped set up and recruit to the ITP registry, and we've helped multiple sites contribute data to the FLIGHT study, which you'll be hearing about or have heard about earlier on today. But more relevant to this talk is that we've led on the Flash Mob IVIG study, and I'm going to talk to you about that now. Intravenous immunoglobulin, or IVIG, is used to rapidly correct platelet counts in patients with ITP. It tends to be used if patients have major bleeding or require interventional procedures that need that rapid increase in platelet count. Historical evidence suggests that 80% of patients treated with it respond and have an increase in the platelet count, and that the time to response is about 2 to 4 days, and the duration of that response is 2 to 4 weeks. It does, however, have some side effects and problems associated with it. Firstly, that it's a blood product, albeit highly processed, and some of the resultant infection and reaction risks that go along with that. There's also been association with thrombosis, but that might actually be due to historic contamination with procoagulant proteins. Importantly, however, it's an increasingly scarce resource because of difficulties in donation and fractionation, but also with increasing use across multiple indications. The evidence for the use of IVIG goes back 40 years, and the pivotal study was in the Lancet in 1981, where 13 children were given 0.4 grams per kilo of IVIG once a day for 5 days, a total of 2 grams per kilo. In adults, the first pivotal study was in 1985. They were getting the same dosing strategy, but this time the study included 6 adults. Over time, this dosing strategy has changed to, rather than being 2 grams per kilo given total over the course of 5 days, it's actually given as 1 gram per kilo for 2 days. This was first described by Bertrand Godot in Blood in 1983, where patients had 1 gram per kilo over 2 days, or a comparator 2 grams per kilo over 2 days, and there was no difference between the responses in these patients. However, since the late 90s, there's been increasing use for increasing indications for IVIG, but also reduced UK supply, primarily at that time due to variant CJD. In 2008, the Department of Health issued guidelines to try and limit the off-label prescribing, effectively being very strict on what you could and what you couldn't use IVIG for. In 2011, the American Society of Hematology issued guidance, specifically in ITP, that how to use IVIG, saying that actually the dose should initially be 1 gram per kilo as a one-off dose, and then, if necessary, that dose could be repeated. The evidence for that is, to quote another Bertrand Godot study from 1999 that I'll go into in detail a bit later. But this clearly wasn't enough, and actually in 2012 the NHS set up IVIG committees within each hospital to further manage and authorise individual IVIG use for individual patients. It still didn't seem to have the desired effect, however, and so in 2016, NHS England had to issue further guidance, specifically this time on dosing of IVIG in ITP. They said that they should be given a 1 gram per kilogram dose as a one-off, and that this dose should be repeated only if considered necessary at day 7, if there was a failure to achieve a hemostatically adequate platelet count. The evidence they gave for this was the 2011 American Society of Hematology guidelines I've just described to you, but they actually say something slightly different. They quote the Godot British Journal of Haematology 1999 paper as the evidence, and this is actually a trial of a one-off dose of 1 gram per kilo versus a one-off dose of 0.5 grams per kilo with a total of 35 patients. And in those given 1 gram per kilo, the 18 patients given that dose, 2/3 of them responded, and the remaining 6 patients given a further dose on day 4. And of those given the 0.5 grams per kilo, only 4 of 17 patients responded, and the remaining 13 patients were then given a further 0.75 grams per kilo on days 4 and 5, and a lot of them responded. What you can see here is that from the evidence is it doesn't really actually match what the guidelines say. And it was a fear of the ITP Forum that the lack of evidence base for the 2016 Department of Health guidelines might be a barrier for their adoption by UK haematologists. And so, along with the ITP Forum, we at HaemSTAR set about to audit UK practice of IVIG dosing. We did this project in 2018 and set about to collect data from all patients given IVIG over a preceding 5-year period. Obviously, this time frame had part of it before the Department of Health guidelines, and so we actually audited against the American Society of Hematology guidelines that were published in 2011. The primary outcome was the proportion of IVIG treatment doses that were given according to the guidelines, i.e. 1 gram per kilo on one day with a subsequent dose more than 24 hours later if required, and secondary outcomes looking at the indication for IVIG, the platelet count when IVIG was started, the complete response and overall response rate as well as durations of those responses, and also to explore correlations between various other factors. The audit standards we used were that treatment should only be administered in patients whose platelet count was less than 30, that it should only be used when a rapid increase in platelet count is required, that it can be used as a first-line treatment only if corticosteroids are contraindicated, that if the IVIG is used, the dose should initially be 1 gram per kilo as a one-off dose, but the dose may be repeated if necessary after sufficient time has passed to allow for a response assessment. The standards were against treatment being used in asymptomatic patients who had platelet counts of greater than 30. The study timeline then was that this study was conceptualized in December 2017, and then presented to try and achieve some funding in January 2018, we kindly received some money from the Katie Bolam Award, which was administered by the Scientific and Academic Coagulation Consortium, as well as some funding from West Midlands NIHR Local Clinical Research Network. Then, between February and August 2018, we developed a study protocol, and then in August we sent out invitations to various sites to take part. And by October, we had 39 sites registered. We invited sites to enter data between October and December 2018, and in that time we were able to collect data on 978 patients, although 17 of those didn't have enough data to include in the analysis, but that left 961 patients. And in those, we had data from their first treatment with IVIG and then subsequent treatments in 230 of those 961 patients. The work was performed simultaneously by 134 people that were coordinated by HaemSTAR, and all their names are up in front of you, and we are very grateful for their input. In terms of results of the study, you can see that the patients we recruited were fairly representative of the UK population, a fairly equal mix of male and female, mostly being primary ITP, but with a quarter having secondary ITP, and a small number of pregnant patients. Most of the patients had been recently diagnosed with ITP, but again, a quarter had chronic ITP, and there were a mixture of number of lines of prior treatment. You'll remember that our primary outcome was to look at dosing of IVIG, and we categorized the dosing strategies into all of these 7 you see in front of you. You'll see that the majority actually used 1 gram per kilo on 2 consecutive days, and that only 36% were dosed according to guidelines. In terms of indications for IVIG, there are only very few cases where a valid indication wasn't apparent. And in terms of platelet count, 75% of patients had a platelet count of less than 30 at the time they were given IVIG, but actually those that had a count of more than 30 actually had reasonable urgent indications where surgery was required that required a platelet count of more than 50 or more than 100. In terms of the more exploratory outcomes, you can see that our response rates we saw were similar to those reported in historical groups, but that patients are more likely to achieve a platelet count of more than 30, with 88% achieving that, but only 64 achieving a platelet count greater than 100. And the median time to response is also similar to previous studies. It took a median of 3 days to get to a platelet count of 30, but slightly longer, a median of 8 days to get to a platelet count of 100. And that the response durations were, again, similar to previously reported, 17 days for the platelet count to remain above 30 and 12 days median for the duration of platelet count above 100 before the response was lost. But were there any factors that influenced this outcome? The main drive of the study was to look at dose. And if we compare those patients who had 1 gram per kilo of IVIG on a single day versus those who had it on 2 consecutive days, we can see that there was no difference in their ability to achieve a platelet count of 30 or to achieve a platelet count of 100. We also see that there was also no difference in the length of time that the platelet count spent above those 2 thresholds. We then looked further at all the different dosing strategies used and actually found no difference between any of them, except for a trend to a poorer response in those who were given less than 0.8 grams per kilogram on a single day. But there weren't very many patients in this particular group, and I suspect this study was underpowered to detect differences here. By multivariate analysis, we did find a number of factors that influence platelet count response, however, that patients with primary ITP had a better response than those with secondary ITP, with a greater likelihood of achieving a platelet count of 30 and 100. We also found that patients who had chronic ITP had shorter response durations than those with ITP that had so far lasted less than 12 months. We also looked at patients who had sequential treatments with IVIG, and we found that their first treatment had a better response than their second treatment, but the response duration of the first or second treatment were the same. Another important observation of the study is that we're able to look at UK haematologists' habits in terms of dose capping. We found that patients who weighed more than 100 kilos actually were given lower doses. They had 0.7 grams per kilo rather than 0.9 grams per kilo, which was the average dose given to those patients who weighed less than 100 kilograms. I've not got the data here to show you, but actually there was no difference in outcome between these two groups in terms of platelet responses. So in summary, more than 50% of IVIG treatments for ITP are not dosed according to guidelines. The reason for this is probably because the data used to formulate the guidelines are based on studies with low numbers of patients, or actually no direct comparison of 1 gram per kilo on 1 day versus 2 days to look at outcomes. Actually, our project has shown this outcome. There is no difference between 1 or 2 1 gram per kilo doses in terms of platelet responses. We've also shown that if all English clinicians followed the guidelines, this would reduce annual spend on IVIG by £1.5 million. So again, the take-home messages. Firstly, it is safe to follow the NHS England guidelines for IVIG dosing of ITP. If everyone did this, in England alone, there'd be huge cost savings in the NHS. And there is also evidence that UK haematologists dose cap IVIG if the patient's weight is above 100 kilograms, and that this appears to be safe. Thank you very much for your time. And also thank you very much to the 134 collaborators who took part in this study. I want to make clear that all of those people are listed as PubMed citable collaborators on the publication that came out in the British Journal of Haematology last year. And that it is HaemSTAR authorship policy that this is the case across all of the studies that we lead on.